So my task at the moment is to think about what today's big ideas were, and of course they were about more than just optimizing weight gain, which is what we had hoped for, because of the original committee's, the 2009 committee's statement that the big picture here is that pregnancy weight gain is an effect modifier, using epidemiologic language. It is modifying the effect of the woman's state when she enters pregnancy. So what we really need is a radical change in the way women are cared for. And one of the things that we're hoping in this workshop to do is to explore that concept as well as gestational weight gain. And the end game here is a workshop with a workshop report that gets some of the ideas we've heard today out into the real world, because what we can report in from the workshop has to have been said at the workshop. So here's my chance to say it. So I hope I've caught some sense of the big ideas, and I was taking lots of fiddling with this as you all were talking, so let's hope I did pretty well. So first big idea came from Michael Liu, as he called his new slogan, Before, Between, and Beyond. And what he's trying to do there, of course, is to connect preconceptual, prenatal, and postnatal care to post-reproductive care, because we're finding more and more, whether we look at pregnancy or we look at lactation, what went on there matters for women's later health. This is a way to connect pregnancy to women's health more generally, for the Maternal and Child Health Bureau to have an excuse to talk to the Office of Women's Health, not that they need one, but this is part of the deal here. One thing we've mentioned is that preconceptional care is especially difficult, that first piece, because we have 50% or approximately that unplanned pregnancies in this country. And as one of you said, said we should be digging deeper. Well, this is one place we really do need to dig deeper. It's much easier in Europe, where a much higher proportion of women use IUDs as their contraceptives. They come to have them removed. That is your moment to talk about making sure that you're not taking this IUD out until you're really ready to get pregnant. And when you do, here's what you need to know. I think the last part of this postpartum care I could describe politely as only minimally developed in this country. We have that one visit. Could we not think over the whole maternal mortality interval? Could we not do more with this? We are planning for, as we heard, 70% of women are going to have another baby. Could we not be thinking about that? We've heard that we need much more attention to a public health approach to have women conceive at a healthy weight. It's too late once she got pregnant, because she can no longer conceive at a healthy weight if she's already pregnant, and she wasn't when she got pregnant. And we need better surveillance of gestational weight gain to track how we're doing, to make it clear what works, what doesn't work, when we need to make a change in course. Second big idea is changing the structure of prenatal care. We heard lots of ideas about this. The first one is to start earlier. I hadn't really thought about pregnancy test kits as a way, as having displaced the pregnancy diagnosis visit, that very first visit when they wanted you in so early before. And now, since you know you're pregnant, you don't need to come until you're 12 weeks. Well, actually not. As Dr. Sass said, we are building a new human being. We need to be there as soon as we can. We talked about team-based plans for prenatal care, visits with appropriate providers, trying to see for each woman, does she need a nutritionist? Does she need a physical therapist? Does she need the whole panoply of services offered by maternal fetal medicine? Whatever it is, trying to come up with a plan that works for her, and then implementing that plan as a healthcare team with cross referrals. I loved lots of the ideas. I'll start with to see your doctor on the pregnancy test kits. I think that's a great idea, along with the warnings. Let's not put them in a black box. Let's put them in a colorful, positive box. Prenatal vitamins, that's another place you could label. You could change your food labels. Heaven knows we're trying stoplights and a lot of other things on food labels. There are possibilities there. and the bathroom scale as a weight gain tool, but of course you have to be able to see the bathroom scale, and you have to have a bathroom scale. Lots of women in this country don't have a bathroom scale, and if they stood on it, it wouldn't go far enough, or they wouldn't be able to see it, especially as they become more pregnant. We need some better ideas here. But nonetheless, the concept that you could be reinforcing that message at home with women, I think, is an important one. And the one from Suzanne Phelan's research that early excessive weight gain is difficult to reverse. So we really do need to be seeing women earlier. This is a good reason for earlier care, because if women in their first trimester have already gained 10 pounds, we are behind. Another big idea was motivating women. The concept that women can already tell you what they should do. They have a strong knowledge base, but they need to be motivated to make those changes, to make the decision, to choose to change on their way to gaining within the guidelines. And I would say we need to motivate women not just to gain within the guidelines, but the mechanism for that is engaging in other desired wellness behaviors. So it isn't just motivational interviewing, it's all about the totality of what you want women to do. Dr. Connery began by saying to us, we ought to ask women about what their reproductive goals are so that we can talk to them at every visit. This is an opportunity for dialogue, not just for OBGYNs, but especially for family care practitioners. That we should be doing motivational interviewing, and we can only do that if we adequately train the people who are doing it to do it well and give them the full range of tools they need. They won't do this if they don't have answers. We need to help them find the answers in their communities, places for women to go to get the services that everybody can agree they need. A number of you suggested that it was important to have incremental, achievable goals with frequent follow-up. Motivational interviewing toward some big goal that a woman doesn't see herself as being able to achieve is much less effective than motivating her to solve immediate problems, achieve incremental goals, and keep coming back with bigger, better, and more appropriate goals. I was very interested to hear that women want to self-educate. I'd never thought of sort of putting it that way, but if you look at all the time they spend on the internet and how popular Text for Baby and all of the other baby websites are, of course they want to self-educate. Check the box for the committee on our infographic. You know, that's a tool for that purpose. We could do more with that. You know, if we think about it, here's a start for that. How could we build onto that into something more? I say we, meaning everybody in this room, because the committee's budget is about spent. But the concept that there could be such an item related to pregnancy, that's really a novel concept, and we gave you the first round of that. And all of this stuff about motivational interviewing and getting women to make changes and changing prenatal care to some kind of team approach requires a change in the reimbursement for pregnancy care, the structure of reimbursement for pregnancy care, because we need to be reimbursing people for care who are not now reimbursed. Check all those dietitians who are giving that service. But we also need to be thinking broadly about who needs to be on that team, and that may be other people who need to be reimbursed. Another way to think about this is changing the structure of the care of women, of women's reproductive care. Sorry about the typo here. We've talked about a patient-centered medical home. Pardon me if I leap outside the box and say we need a patient-centered health home for women. Yay! And started after pediatric care ends, because women fall into this big gaping hole after pediatric care ends. Picking them up in college is nice for women who go to college, but not everybody does. And not every college health service is prepared to do anything of this sort. I think we need to think bigger here. It seems that we need kind of a larger standard of care for maternal and child health. Thinking bigger here, what is it? What are all the things we're trying to do? Where can we really do big things? And if we want to improve maternal and child health, thinking about this health home for women, thinking of it starting as she becomes an adult and going throughout the rest of her life would be a really big improvement. Pardon me if I editorialize, but we need to stop treating women's health care just like we do men's health care, which is nothing's happening until they're about 50. I'm sorry, there's all the action for women before they're 50. We need to make this much better. I love Dr. Sass's description of having hospice care for pregnant women and the newborn, continuing for the first 1,000 days. The first 1,000 days is something that's in the air in international nutrition, less obvious perhaps domestically. But the idea that we would be providing surrounding care for the pregnant woman that made life less stressful, that we would continue this care with the baby, that he was thinking about having a group around that woman. Other countries still have both postnatal nursing visits. I'll pick on the Danes. What they do is they have a couple of postnatal visits by a nurse, public health nurse, who then sets up a group of other women in the same neighborhood who've had a delivery at about the same time, gets that group rolling, supports the group it's necessary, but they continue to meet until their children go to school. So it's setting up a woman's group around that woman, and some of them are wildly successful and some of them are not wildly successful, but we're not even trying. And we've lost nearly all of our nurse home visitors, at least for prenatal and postnatal care. And my last thought here is all about leverage. I began by talking about leverage and showing you a diagram and saying that leverage was available at many places in this diagram. And we were showing our leverage mostly on the right side, but not exclusively limited to that. And this workshop is leveraged someplace else in that diagram, in fact, across the whole range of the diagram, given who's in the audience. So there's many venues, there are many venues possible for disseminating the guidelines. Visible leadership is really quite essential. We've had visible leadership in terms of these committees and the ideas that they have generated. The committee has talked about engaging, whether it's Dr. Oz, the Surgeon General, or the First Lady. We've batted all those ideas around. But I think those are places we can move forward to, perhaps with the help of Michael Liu and also the Office of Women's Health, if that's possible. I also think leverage is available in many places, all the way from menarche until after the birth of the last child, thinking about the woman's whole potential reproductive career, which begins at menarche and certainly ends some period of time after the birth of her last child. We've heard that you need to start early, really very, very early, that we could return health education to the curriculum in the K through 12 areas. We've heard that children could be motivators of their parents, whether it's buckling up seat belts or using your birth control. So somehow I find it a little hard to imagine children motivating their parents to use birth control, but you know, we could think about that. But we also heard about linking children, parents and children in care, that parents being motivated to be fit themselves, for their children to be able to engage their children, but also linking the parents' care visits and the child's care visits for at adolescence, at the point where we're thinking about HPV vaccination. Can we link the care of the adolescents into their future reproductive careers? I just think there are a lot of places here where we could act, and each of us have different places in this list of wonderful opportunities where we have our own bully pulpit. We have policy levers we can pull. We have motivation we can give, whether it's to our individual patients, our professional societies, or in my case, the 120 students in global health I was teaching the other day, or my 90 students in public health nutrition. They're undergrads. They're not pregnant yet. Contraception is a word they need to hear about. They've been hearing about it, But pregnancy is also something they need to hear about, and breastfeeding too. So each of us has a place where we have something we can do, and I hope you will take advantage of your special place in this. I would like to end by saying thank you to all of you who have participated, whether you're in the room with us or not. I would particularly like to thank the members of the committee who have developed today's workshop. And I would like to thank Ann Yakteen as our supporter for this, and Jennifer Gutman before her. Ann has really, really knocked it out of the park here for this committee. And the Maternal and Child Health Bureau from Michelle Lawler as the sponsor for this committee's activities. Thank you all very much.